All right, so we're recording now. And Mitch will take it once we get started. I'll kind of advance the slides for him, so I'll have to share those. All right. How's everybody in Leander? Good? Thumbs up? Awesome. Appreciate y'all joining us. All right, I'm going to go ahead and kind of get the share pulled up. 11:05, we'll get started. Mitch, just whenever you need me to advance a slide, just kind of say next slide.
Yep, will do.
All right, so at this point, it says I'm sharing. Everybody see kind of slide secondary upper extremity DVT. Yep.
Yeah.
Cool. Okay. So Mitch, I'll let you take it away. You can introduce yourself real quick if you'd like, and then we'll just tell me next slide and we'll go from there.
Sounds good. My name is Mitch Mauder. I'm a physical therapist up at Carroll Clinic here in Frisco. I've been here, I think, going on 3 years now. I originally started at the Dallas Clinic, but I've been here for Frisco one about a year and a half. It's been great. I appreciate you guys taking the time to do this. We're going to talk to you about a case that I had. It was an upper extremity DVT following a surgery, shoulder surgery. So go ahead and hit the next slide there for me, James. So just kind of a clinical don't miss. Although upper extremity, DVTs are pretty rare, they can be potentially fatal. Some percentages to look at here. It only happened in 0.17 to 0.54 cases, so a lot less common than your lower extremity DVT, which is important that we start looking for some of these factors. I'm going to hit the next slide, please. So some of my case details, I had a patient, what essentially happened is he was trimming a tree. He fell off a ladder, landing onto his elbow and fractured his arm. So the full diagnosis was a humeral shaft repair, ORIF. He had a biceps tenodesis on the subpectoral region. He had a deltoid tendon repair, and then they used an allograft for a bone augmentation on 3/11/26. So I've been working with him for about 3 weeks at this point. Everything was progressing pretty well in terms of range of motion. He kind of did mention some elbow and forearm pain, but he had fallen off a ladder and landed directly on his elbow. So I really didn't think much of it. But then about 3 weeks into our rehab, he came in to do his normal warm up. I had him on the pulleys, and he mentioned, the pain seems a little bit higher than normal in the elbow region. It was kind of tender to touch for himself. And what really gave me a red flag was he noticed the vascularity was a lot different on his surgical arm versus a non-surgical arm. The veins were really just distended. So then I kind of asked him to move his arm around. I said, "Did anything happen since I seen you last?" He goes, "No, everything's been pretty normal." Once I started palpating, he had a lot of pain in the elbow region. And that's what kind of threw a red flag for me was the vascularity and how tender he was till palpation. So then luckily James was also here. I said, "Let me get a second set of eyes on it. We'll see what's going on." James came over, kind of did the same thing, asked him a few questions. Everything seemed kind of on par. Then when James poked around there, I mean, he almost jumped out of the chair just from a really light poke from a thumb. So at that point, we both thought, hey, this doesn't seem right. Let's at least let your doc know and see what he says. So I had the patient stop doing what we were doing. We just sat in the chair, reached out to the physician, and the physician then said, "Yeah, let's go get him sent off for some imaging." And I'll kind of go over some of those different imaging techniques you can use for a DVT, as well as the ones that we did for our case as well. Go ahead, next slide, please. So when you're thinking about a DVT in the upper extremity or a DVT just in general, something to kind of thing is the Virchow's triad of pathophysiology. And what this is, it describes the three primary pathophysiological factors that can contribute to thrombosis. We're looking at injury, clotting, and stasis. So I'm going to start with the injury portion of this. What started this was an actual injury. So that you're going to have like the damage from that as well, and the surgery, which could lead to some like the traction, the positioning of the arm. That's also going to lead to the clotting factors, where the initial injury, you're going to have inflammation. Then after the surgery, when they're going in doing the surgery, you're going to have all the systemic factors that can cause a blood clot. And then on top of all that, you have the stasis, where you're not going to have any muscle pump or function because the arm is probably going to be in a sling, or they're just not going to want to use it because of pain. Next slide, please. And that kind of leads into my next segment, the sling effect. So when you're sitting with the elbow inflection and the humerus and internal rotation, it can compress some of the major venous structures that run through the upper extremity. So you add all that on top of a surgery with the inflammatory process, it's going to increase your risk for a blood clot within the upper extremity. Next slide. So some of your more textbook red flags is going to be unilateral edema. So you're looking at, is there a lot of fullness through the upper extremity versus the non-surgical arm? You're going to have warmth and redness around the skin and through the venous pathways. And you always want to compare the opposite side as well. So it's very important that we don't just dismiss your standard post-op swelling. And that's what actually kind of threw me for a loop is initially my patient didn't really have some of these clinical red flags. He really didn't have much swelling to begin with. So it didn't really click. He didn't really have a lot of redness either. It was really just the pain and how distended his veins were really what caught my eye. So although these are the clinical textbook things, always try to, use your clinical judgment to say, are there other things going on that might like bring these symptoms ahead that might make you think otherwise. Next slide, please. So when we're talking about diagnosing a DVT, there's two kind of ways to go about it. There's a D-dimer test and there's an ultrasound. Now, the ultrasound is the gold standard. That's the one that we used for our case, but I'll kind of go into some of these just kind of as a refresher and just to improve your general knowledge because I had to look this up myself because it's been a while. So for a D-dimer test, it's a blood test that checks for blood clotting problems. So what it does is it measures the amount of D-dimer, which is a protein in your body that is made when blood clots are broken down. So a positive test would have an increase in D-dimer levels, which would mean that there's a potential clotting problem. Now, the downfall to that is that these levels are often elevated just in general after a surgery. So you're going to get a lot of false positives, and you're not really going to have, or just not good readings. You're going to have a reduced specificity. So the gold standard really is an ultrasound. Like I said, that's what we used for our case, and specifically, it's a compression ultrasound. And what that is, it's just a non-invasive technique used to assess a vein's compressibility. So they're looking at it under ultrasound, they'll apply compression, and a healthy normal vein will collapse completely under pressure. So what you'll see if there is a blood clot, the vein will remain distended even when the compression is applied, and that will then identify a blood clot. Next slide, please. So when you're thinking of the upper extremity, you have three major venous systems. You have your cephalic vein, your median cubital vein, which it also is called your antecubital vein, and then you have your basilic vein. Each of these have important things to consider. With the basilic vein specifically, it's going to propagate into the deep venous system, into the axillary vein, which can really cause a lot of problems. But this one's often treated with anticoagulants for that. My patient specifically, he had thrombosis of all three veins above the elbow region. So, and they were provided anticoagulants for that. Next slide, please.
And then you tell them.
James, you're on mute, I believe.
You're telling me something really fun. I would love to. I'll look it up.
It's got really into flip the coin here. Then.
I don't know. All right. Then we'll finish. And we're gonna probably go on.
Hey, James, you're on mute.
James, I think you're muted.
All right, Mitch, I'm going to turn it back on. Just keep going. We'll see if we can kind of get them going.
Oh, perfect. I'm not seeing the presentation here.
Does it not come back up?
All I see is I see the PowerPoint's up, but it's just the image sources. I'm just seeing a different maybe slide than what you're seeing.
Let me see if I can just stop share. All right. So how about now? What are you seeing?
Still the same slide, image sources. Uh,
All right. I'm gonna try it one more time here.
Yeah, sure.
How are we doing?
Good. Presentation's back up. Still same slide where it says image sources though.
Okay.
Oh, there you go. Now we're getting some. I bounced around for a minute. There you
All right. Sorry about that, everybody.
go.
I was having a little technical difficulty.
Oh, no worries. I think where was that on that? Yeah, this will work here. So something a little bit more specific to the median cubital artery is that this can often be triggered from a peripheral IV. Sometimes having that IV in the vein itself can cause superficial thrombophlebitis, which can then trigger the onset of a blood clot. Or what can happen is this can mask, you can get irritation of the vein there, which can then mask the symptoms of a potential blood clot. So that's something obviously you'd have to know and discuss that with your doc prior than just assuming this, but something to consider as well. Next slide, please. So let's talk a little bit about incidence and risk rates. So obviously, we see upper extremity DVTs a lot less commonly than lower extremity DVTs, and you can see the percentages here. For lower extremity, it's 5%. For an upper extremity, it's less than 1%. So that's what really gives us as physical therapists, a good presence in the clinic is that we're seeing patients every day, and we can put all our knowledge together to detect some of these risk factors for patients and making us a very high value in the clinic. Next slide, please. So in terms of PT management, these are just some like general guidelines. Obviously, pre-diagnosis, if you're suspecting, a potential blood clot, you want to hold off on PT and refer for the appropriate imaging. Within the acute phase, you want to make sure they're on anticoagulants or make sure that at least their PCP is aware of the situation so they can manage it correctly. And once you got the clearance from your physician, start again with range of motion stuff. Luckily for me, this was pretty early on in my case. He was only 3 weeks post-op, so we were really only doing range of motion and mobility stuff anyways. And then once he got the clear from his PCP, I talked to the orthopedic physician. He was good to go on physical therapy, just as long as we weren't doing a lot of strengthening, which he wasn't cleared for anyways. But the biggest thing he said, just to avoid compression, this patient specifically was given a nice machine that has the ice and the compression. He was instructed no more compression, just ice. And then we just kind of progressing as tolerated. Next slide, please. So just a quote for you guys, an upper extremity DVT following shoulder arthroscopy is rare, but potentially fatal. Clinicians must maintain a high index of suspicion. So again, just kind of using our clinical judgment, getting to know the patient as a whole, does this seem abnormal? Is this on par for the patient? And just kind of putting those pieces together to identify any potential risks. Is there any questions from the group? Or maybe anything that you guys have seen that's similar, or how would you handle the situation if you found someone with a blood clot in the meantime?
How did you proceed with therapy after the diagnosis?
Yep. So after the diagnosis, the physician said just keep along with the protocol. Like I said, he was only 3 weeks out, so it was strictly only range of motion stuff. Just avoiding compression was the biggest thing. I didn't do a lot of like active elbow flexion just because with the blood clots being around his bicep, I kind of tried to hold off on that for at least a couple weeks. And honestly, he was kind of having pain with that anyways, so he didn't really want to do it. So it worked out pretty well on that part.
Mitch, can you maybe describe one more time what you were seeing or what was going on that day when you mentioned collateral veins, or they were really kind of something that clued you in?
Yeah, absolutely. Kind of just like I said before, he'd always had the elbow pain right from the beginning, but I've sort of dismissed it a bit just because of his trauma. He fell onto his elbow, so he came in, he just had a lot more pain than normal, and he brought up to me, he's like, "Hey, I feel like my veins are popping out on my one side a lot more than my other side," and that's what really caught my eye. I'm like, "Yeah, you're right. That doesn't look great." And then it just then led me to poking around his elbow, and he was just really tender to palpation. So those are the two big things for me.
Yeah, great. And then the other thing that I would point out to everyone is that it's good to have other folks in the clinic so that you can kind of go, hey, can I get another set of eyes on this? What do you think? You can kind of get both heads together. And then all I did was walk over, kind of look at it, and I don't think I even put enough pressure on the skin to really even deform the skin. And he almost jumped out of the chair. It was pretty unusual. And so that, along with kind of the other things, I think led us both to just go ahead and decide let's let the doctor know and kind of go from there.
Yeah, and I would agree with that. A lot of times, especially if you're just handling it one on one, you kind of get in your head. It's like, am I over exaggerating this? Am I going to start scaring the patient? Maybe I'll just let it slide. But I think it's super beneficial. When in doubt, it never hurts to get a second set of eyes on it because two are better than one, you know? So obviously James has a lot of experience in the field, so I felt comfortable getting his feedback as well. So it's great.
James, you're muted.
Thanks, Dylan. Technical difficulties today. Haven't had fully caffeinated. Mitch, again, I appreciate your time, taking time out of your day and schedule and rearranging things to kind of get this presentation to us and tell us more about your case. For everybody that's here, spread the word, grand rounds. We're going to do this once a month, kind of going forward. And if anybody else has a case that they would like to share, doesn't have to be something significant. It can be something kind of cool or interesting. And I can kind of help you put it together, make the slides, get in touch with you, kind of talk you through it. So, but beyond that, we're going to stop the recording.